An apple a day keeps the doctor away, but what happens if the apple's not working? We're going to be talking about blood thinners and, should we be on aspirin? What about blood thinners? What's going on? So the team's put together a very nice presentation. Tell us more.
So before we begin talking a little bit about those blood thinners, we're going to begin with a little crash course on what a clot actually is, how a clot forms, and the process of hemostasis itself. So blood clotting, also known as coagulation, is a bodily process that occurs when we experience a cut-like injury. And so to prevent excessive bleeding, a type of blood cell known as platelets, as well as proteins within the blood work hand in hand to solve this process. In this process, bleeding is controlled within the blood vessel itself. And so how does a blood actually clot? Well, coagulation works in an intricate step-by-step process. When a vessel is damaged, injured cells within the vessel walls release chemical signals that initiate a cascade to form these clots. And so the first step begins when the injured blood vessel actually undergoes constriction. So the aforementioned chemical signals cause these vessels to then narrow and become thinner to limit the amount of blood that leaks. These chemical signals will then travel throughout the bloodstream to the spleen, the site of where the platelets are stored. And these signals will then induce the release of platelets into the blood, which will then travel to the site of the injury. And at the same time, the walls of the vessel adopt these adhesive properties thanks to their surface proteins, which allow them to capture the platelets as they flow by. Upon attachment, then, the platelets will then undergo a modification to their shape, a type of conformational change. And this will allow them to become tightly attached to the vessel wall itself. Many of these platelets are then able to accumulate and clump together to form what is known as the platelet plug, which you can see in the diagram right in the center. After this stage, the platelets then release a multitude of molecules within the blood that activate specific clotting factors. Clotting factors are classified as serine proteases. And so this word means that they're basically enzymes that speed up the breakdown of other proteins. When inactive, these clotting factors are called zymogens. And when molecules like glycoprotein cofactors make contact, these clotting factors are then activated and can catalyze the next steps within this signaling cascade. One of these factors specifically is called fibrin, which is a thin adhesive protein. This factor serves the purpose of forming a mesh, referred to as the fibrin clot, which you can see in the diagram, that keeps the platelet plug in place. The fibrin clot will then trap red blood cells and then forms what's known as a blood clot. The attached platelets also contract to bring the walls of the blood vessel closer together to help facilitate this repair itself. Now, while our body will usually naturally dissolve the blood clot after the immune system repairs the injury, there are times when it won't. And this is when we see some common implications of clotting. These situations can pose serious health risks, as clots can occur in veins and arteries. When they fail to dissolve, the body's blood flow to the heart and other areas of the body is then restricted. And so this means that our body isn't able to receive the adequate amount of oxygen and nutrients that it requires to function. And other common symptoms will then entail swelling and severe pain. So for instance, deep vein thrombosis, or DVT, is a type of abnormal clot found in the leg that affects nearly 1 million people in the United States yearly alone. At this time, the clot can then dislodge itself and travel to the lungs and become wedged, leading to a pulmonary embolism, which can then be fatal.
So, Amir, you bring up a very interesting concept. So there's clots both in the arterioles. Arteriole is where you bring red blood that's pumped out of the heart, bringing vital organ systems. So, and you're going to talk about that on a heart attack on your right. But a venous clot, or the veins, can also form clots in your legs. And it's kind of interesting is that, as you point out, if they break off, so the symptoms would be things like a swollen leg there on one side. For instance, you had a plane ride for 12 hours, you've been overweight, you just had surgery, you might have cancer. There's actually a scoring system to try to figure this out. And it's usually one side of the body. And so, for instance, if you've been sitting around, you're overweight, you had a 20-hour plane ride, and then all of a sudden you get a swollen leg, and a day or two later you get this terrible shortness of breath, you need to call 911 and go to the hospital, because that can be, like you mentioned, a blood clot that forms in your leg and it goes to the lungs. So it's actually very important to look at that. I see many people with swollen legs on a regular basis, and that's usually both sides of the legs when the heart's not pumping, so the blood backflows into the legs, for instance. So that's called congestive heart failure. So those are some of the clues. So thank you for sharing that. Now tell us about what a heart attack is.
Yeah, for sure. So
Go back one slide. Go back one. Okay, go. No, it's okay. Go ahead. I'm sorry. I'll take it from there. Go ahead.
Sure, no worries. So yeah, in other severe instances, blood clots can then be found to block the flow of blood and oxygen to the brain. And this process is typically known as atherosclerosis, where you have the narrowing of those arteries. And in this case, the blood clots then form and are insoluble in areas where the arteries have already narrowed by what's called fatty deposits. And this results in the most common type of stroke, known as an ischemic stroke. So that's typically when we have limited blood flow to the brain. In terms of a heart attack or blood flow to the heart itself, if a blood clot then narrows an artery leading to the heart muscle, this is typically known as arterial thrombosis, in which a heart attack can then be induced. And in this specific situation, the heart is then unable to receive the oxygen and blood supply that it needs to carry out its own function of pumping out the blood to the rest of the body, which then ultimately will lead to that circulatory failure that is observed in a heart attack.
So that's actually kind of important. So, Amir, if you can show me that that white clot, that white plaque in that vessel, is that, and then you can see the in there. Can you show us? Can you just highlight? So that's basically what a plaque looks like. That white cheesy material, things like cholesterol, blood pressure, diabetes, overweight, not eating well, high blood pressure, high LP.
I think Dr. Curnew just lagged out there. We'll give it a minute or so.
I'm back again. I just had a heart attack. You see, what happened? I just lost connectivity. So what I'm saying is that you get this. It goes from a stable to a very unstable position. You know, you might think maybe it's bad indigestion, maybe it's something else going on. So in this circumstance, that's a heart attack. Now it's very interesting, and we're going to explore this a little bit right now. Is that this message here, if you have a stable cheesy plaque on the top one on there is that you leave it alone with medicines most of the time. It's when the bottom of that clot forms, that's when you need to have an angioplasty and bypass surgery. We now have 3 or 4 big clinical trials saying that if we do an angioplasty for chronic stable disease, we form more blood clots, we cause more heart attacks. What you're doing is you're pumping 2 to 5 atmospheres of pressure into the vessel and you're cracking it. When it comes to the left, the stroke is that, you know, you don't get stroke on normal vessels. These are diseased vessels. And one of the things people say, I have this 90% lesion in my left side, 50%, 60%, fix it. Well, you know what? The best way of fixing it is risk factor modification, cholesterol, blood pressure, medications like aspirin therapy. It's not surgery. It's not angioplasty as a #1 therapy. So people say fix these things. Fixing these things can actually lead to more strokes and more heart attacks. So please be careful. I know how we manage this. So I think that's beautiful how you showed us those pictures. But I want people to that concept of not rushing to have a procedure done. It's like saying your foundation is cracked. You got to fix the foundations. Let's fix that foundation and stop chasing the cracks. Tell us more.
Okay, so we've seen how clots can cause issues, and this is when we want to thin out the clots. And we can do this using anticoagulants and antiplatelets. So there are different types of anticoagulants, which are also known as blood thinners. They are used to interrupt the coagulation cascade, and they work to prevent blood clots from forming. So there are three major types. There are vitamin K antagonists, low molecular weight heparins, and direct oral anticoagulants, which have two other subtypes, direct thrombin inhibitors and direct factor 10A inhibitors. So one of the most common examples of a vitamin K inhibitor, which was one of the types I just mentioned, is warfarin. And warfarin functions by completely inhibiting the vitamin K, it's called epoxide reductase complex, which essentially just prevents vitamin K from activating. And this results in you're producing less active clotting factors. So this is how warfarin can interrupt your clotting process. The second group of common anticoagulants is heparin. There are multiple types of heparin, and they act on several different factors in your clotting process, as shown in this diagram. And these different types of heparin, they tend to differ by their structure. And the one that's commonly prescribed is low molecular weight heparin, which inhibits what's called factor 10A. It's shown at the bottom of this diagram. And that's how this will affect the clotting process. And then the last group of anticoagulants are the direct oral anticoagulants, or the DOACs. They mostly, well, they include the following drugs, so rivaroxaban, apixaban, edoxaban, and dabigatran. And these, as you see, they point to the factors in the clotting process that they inhibit. So in this way, they interrupt the clotting process. And then there are antiplatelets. So unlike anticoagulants, antiplatelets affect the activation of the platelets. And as you can see in the diagram on the right, different antiplatelets like clopidogrel and aspirin, they affect different parts that are important for activating the platelet, and they make it harder for the platelet to clump up and form that plug to prevent your blood from leaking. So now we know about anticoagulants and antiplatelets, but why do we use them, right? So we mostly use them to prevent stroke and heart attack. As we saw in the previous slides, clots are very dangerous for stroke and heart attack. So we use the anticoagulants to thin them and hopefully prevent them. And so if you're prescribed anticoagulants or antiplatelets by Dr. Curnew, please follow his instructions on taking them. So there are a few tests that healthcare providers may look at to see if a patient needs anticoagulants. One of the most common is called the APPT test, which is shown here. So this basically it tests how long it takes for your blood to clot, and the normal range is around 20 to 35 seconds. So these are just some common conditions where if you have or have experienced any of these conditions, your doctor may consider putting you on anticoagulants to prevent recurring problems in the future. Okay, so now let's look at some clinical trials that have been conducted to test the effectiveness and compare different anticoagulants and antiplatelets. So the first is the COMPASS trial. So we said that anticoagulants work by slowing down the process of making clots. Then we also talked about antiplatelets, which make your platelets, it makes it more difficult for them to clump up. And a very well-known antiplatelet is aspirin. And there have been many different clinical trials that have compared the effectiveness of aspirin to various other anticoagulants. And the most well-known is, or one of the most well-known is the COMPASS trial. So if you go to the next slide, the COMPASS trial wanted to see which of these three therapies shown was the most effective at preventing future cardiovascular events. So specifically like cardiovascular death or stroke and myocardial infarction, which is like heart attack, in patients who already had heart disease. So the three treatments were taking rivaroxaban, which is an anticoagulant alone, versus taking aspirin alone, versus taking both at the same time.
Well, this is actually a very important trial, as you point out. So we define the world between primary prevention and secondary prevention. So primary prevention is you may have some blockages, but you haven't had chest pain, you haven't had a stroke, you haven't had a heart attack yet. You have some blockage formation. And secondary prevention means you've already had a heart attack. You already had a stroke. Remember when you saw those pictures, that cheesy plaque with a clot in there. So you know when that happens. So it's not a little bit of disease, it's a lot more disease and bad things that happen to you. So for clots, we use blood thinners, as you point out. For heart disease, we often use platelets. And you're saying, what about the combination of both? And these are very smart people. They used actually both aspirin, an antiplatelet, prevents the clumping of platelets, and then rivaroxaban, or called Xarelto, at a much smaller dose. So when you have big clots for blood clots, we use 15 to 20 milligrams at a time. And when you're in a situation where these low doses use 2.5 twice a day. So that was a really kind of neat strategy. So what happened when you use very low dose of two of these drugs together? What happened?
So after 3 years of follow-up, they found that the group taking the combination of rivaroxaban and aspirin experienced 24% fewer cardiovascular events compared to the aspirin group. And if you compare the aspirin group with the rivaroxaban group, the differences were not that significant. So really just the combination group was the greatest difference among the three. However, they also found that the rivaroxaban group, as well as the combination group, had more major bleeding events, and specifically the combination group had 70% more major bleeding events. And this leads to the perception that the risks of taking rivaroxaban and aspirin together may outweigh the benefits, but this isn't necessarily true, as we'll see in the next slide. So this was a 2020 study that further analyzed the results of the COMPASS study. And before I point out the graphs, one thing I want to point out is that this study found that the COMPASS trial actually used a modified definition of major bleeding that was more broad than the official one that was created by the International Society on Thrombosis and Hemostasis. So what that means is that many of the major bleeding events that was recorded in the COMPASS trial would not have been considered major in other large trials. And in fact, the main contributors to that 70% increase in major bleeding events, it was not due to fatal or anything involving bleeding into critical organs. And these would have been considered more severe bleeding events, and events like that, so events that were fatal or involved critical organs, were actually quite low and not that different among the three different treatments that they tested. So if you look at the slide at the bottom two, the graphs in red, these show the risk of experiencing a major bleeding event over time for those on rivaroxaban and aspirin together versus those who are only taking aspirin. It's a bit hard to see because the graph is a bit small, but the dotted line represents people who only took aspirin, and that's the line at the bottom. And then the solid red line represents those who are taking the combination therapy. And as you can see, these lines are not very far apart, and around the 3-year mark, the lines actually even start to meet. So this shows that the risk over time starts to not become as great between the two different treatments. And then if you look at the graph on the right, these lines are practically touching the whole time. So the risk is really not that different, especially when you look over a long-term period. And then if you look at the graphs in blue above, these show the risk of experiencing death, stroke, or a heart attack over time while either taking aspirin alone or taking the combination therapy. And it shows that taking aspirin alone is consistently more risky and gets riskier with time compared to taking the combination therapy. So these graphs really show that it's important to look at the differences in risk and safety over time for treatments like these, which are typically long-term and potentially lifelong.
Actually, just go backtrack 2 slides. So to me, is that this is the art of medicine. So is it in the compass, doctors pick patients who had lots of blockage, and the group of patients got the most benefit. You had the people with blocked arteries in their neck, their heart, or their legs. And the ones in the legs had the most benefit in this trial, and they even prevented limb amputation. However, bleeding is bleeding, and you shouldn't bleed to death. If you bleed, you stop the bleeding, but it's never a good thing. Bleeding is never a healthy phenomenon. So I think the art of medicine is to figure out who's at risk for these plaque ruptures and having strokes and heart attacks and limb amputation, and who's risk at bleeding. And as you get older and frail, the risk of bleeding goes up, and if you're already anemic. So this is something that I struggle with on every day of my life. Do I think your risk of bleeding is higher, or do I think your risk of a stroke or a heart attack is higher? And that's what medicine's all about, is just to figure this out. And my leading problem right now is seeing people that bleed or have low hemoglobin. I see that every day of my life on a regular basis. So I don't think this is a trivial problem. I think it's a big problem, and trying to stabilize the vessels. So I want to stabilize the vessels with other ways, with diet and exercise, lowering cholesterol, lowering blood pressure, and using the right blood thinners in the right circumstance, I think, is important. So thanks for sharing that. Tell us more.
So there was another trial called the Averroes trial, and here they once again compared aspirin to an anticoagulant, but this time they tested apixaban versus aspirin in patients with atrial fibrillation, which is when your heart beats really fast and irregularly, and this kind of beating can lead to clots in your heart. And so essentially, apixaban was found to be more effective in preventing stroke and embolism caused by these clots. But this effect was actually very pronounced in patients who were 85 or older, as their risk was reduced by nearly 87%. And then additionally, the risk of major bleeding in general was pretty similar between the two groups, but there was less intracranial bleeding in the groups that took apixaban. And once again, they found that this difference was very pronounced in those who were 85 or older, as they experienced almost 83% fewer intracranial bleeding incidences.
You just go back again one more time. So basically, if you have an irregular heartbeat called atrial fibrillation, aspirin decreases the risk of stroke by about 10 to 15%. Blood thinners such as warfarin, Coumadin, apixaban, Xarelto, dabigatran, edoxaban, they decrease the risk of stroke by 70%. And so that circumstance, we always try to use strong blood thinners, those things that, remember that mesh, that cheesy fibrin deposit, these blood thinners work really well in that circumstance. But overall, they have a higher risk of bleeding compared to aspirin therapy. Aspirin does have significant risk of bleeding. The most common cause of bleeding is internally somewhere in your gut, somewhere, a slow leak. And so picking the right blood thinner at the right time. So we use it's something called a CHAD scoring system. And so basically we know if C is for congestive heart failure, H is for high blood pressure, A is for age over 65, D is for diabetes, S for stroke or TIA. If you're someone who has atrial fibrillation over the age of 65 years of age, you'd be foolish not to consider a full blood thinner to prevent stroke. If you have diabetes, high blood pressure, previous stroke, those are the people that need to be on blood thinners. You can be intermittent or permanent, and that's what time we spend our time looking at this. Then you have to balance that with bleeding. If you have recurrent nosebleeds, GI bleeds, intracranial bleeds, I think most of us would rather bleed inside our stomach or our nose than bleed inside our brain or have a stroke. So we have to figure that out. But bleeding is a major issue and something we have to balance as you become older and more frail. And one of the things to me is that please keep moving, keep walking. And if you're unstable on your feet, make sure you have a walker and the appropriate devices. If you're falling, make sure you talk to your doctors, go to a fall program, learn Tai Chi, go to seniors program for improving your stability. These are all very important considerations. Thank you so much. Share us more.
So Plavix and aspirin are two antiplatelets. So now we'll kind of compare which is more effective. So we've seen the Avros trial and the Compass trial, and in the Capri trial, they compared aspirin to an antiplatelet called Plavix, also known as clopidogrel, in reducing risk of negative cardiovascular events in patients who had recently experienced either myocardial infarction, ischemic stroke, or peripheral arterial disease. And they found that the relative risk reduction when taking Plavix was around 7.4% for those who had myocardial infarction, 7.3% for those who had a stroke, and 23.8% for those who had arterial or peripheral arterial disease. And as you can see from the graph, you can see here that those who were on Plavix consistently had lower risk than patients who were on aspirin. And then on top of that, those who took aspirin saw around 34% more incidences of gastrointestinal bleeding than those who took Plavix. So this not only shows that Plavix is more effective, it also shows that it's potentially safer than aspirin in reducing further cardiovascular events.
So this trial is an extremely old trial, very old trial. The background bleeding risk is roughly 1%. You add aspirin to that, it goes up to about 2% per year. And this compared 325 of aspirin versus 75 milligrams clopidogrel. At that time, there was a huge difference in cost, and it wasn't felt to be a cost-effective strategy. But we're going to learn that maybe we can do better with our current scheme of blood thinners. So it's a little bit better. But you know what? Is that a better way of preventing a heart attack is not to smoke. If you take a high dose of a cholesterol pill and a ezetimibe, you can lower your risk of heart disease by about 60%. So we can do better job at preventing stroke in a more safer way. So this is very interesting. This came out a long time ago. We all said, and we didn't really apply that to clinical practice on a regular basis. But let's learn more. Tell us more. Next slide, please. Do you want me to take over from here?
Yeah, that'd be great. Thank you.
Okay. So then there's the series of trials that looked at aspirin and clopidogrel. After angioplasty and stenting, we traditionally used aspirin and clopidogrel or aspirin ticagrelor for about a year or so after an angioplasty, because after an angioplasty, the stent can form a blood clot and it can block off over time. And the standard of care used to be aspirin and Plavix for about a year, but what we're learning is that we can maybe shorten that and change that. Next slide, please. So we have a series of trials that suggest that maybe if we replace clopidogrel with aspirin, because usually after a year we would stop the aspirin. We stop the clopidogrel and keep the aspirin going. Maybe we should do it the other way around, because you've shown initially in Capri that Plavix was better than aspirin, a little bit better, a little bit safer. But the traditional approach for decades was to, after about a year or so, would be to stop the after being on aspirin and clopidogrel or aspirin ticagrelor to just be on aspirin afterwards. So this study suggests maybe we got the wrong antiplatelet agent. Next slide, please. So we have a whole series of trials in this area that suggest. And this is a new meta-analysis. Meta-analysis is pooling of all data. This is 7 trials, 24,000 patients that suggests that maybe the blood thinner that we should be using should be clopidogrel. Remember that trial called Capri that you showed us? This was prior to the stenting error to a major degree. So I'm now considering actually, instead of aspirin long-term, if you have blocked arteries, clopidogrel or Plavix is a more long-term favorable agent. It's a little bit better and a little bit safer. It's not, it's not like a dramatic difference, but every, 10 or 15% better and less bleeding is a good thing. And it's rare to see both benefit and safety on the same side of this. So next slide, please. So my approach right now is that here's another meta-analysis showing the same thing. You're a little bit better, 70% reduction in clopidogrel of having a heart attack compared to aspirin therapy. Next slide, please. And this was in an Asian population. This shows about things like CRP, markers of inflammation, showing a beneficial effect of clopidogrel versus aspirin therapy. Next slide, please. So we're now going to an era. If you go backtrack another slide, go backtrack one more slide again, backtrack one more slide again, just showing this data right now. So I am thinking, do we have the price on this one over here or not? What we're going to is that clopidogrel looks better than aspirin in both patients who have plaque rupture and maybe in stable disease as well. Next slide, please. And emerge, keep going back another try slower. Next slide, please. Now this is LP(a). This is something we should start to measure in the last 2 years in our clinic. LP(a) is this molecule that it's an LDL cholesterol molecule. It also has this thing called this kringle called plasminogen looking like it. So it's somewhere, it's a cholesterol particle, but it also causes blood clot formation. And there's now a little bit of data suggests that maybe if you have a high LP(a), you maybe should be considered an antiplatelet like aspirin or Plavix. But this still requires a fair bit of work, and this is something for the future right now. This is not the current practice to go on antiplatelet agent at this stage. Next slide, please. And now that clopidogrel has gone generic, it now costs somewhere around 25 to 35 cents a tablet. At one time, it was over $2 a day. Ticagrelor, our sister drug, was $3 a day. So it now becomes, aspirin, depending where you buy it, the more you buy, the more you save. You can buy over-the-counter aspirin for pennies a day. And most of the time, I don't even write a prescription for aspirin because the cost of the prescription is more than the cost of aspirin. But it really looks like right now is that we should think about using Plavix as a long-term antiplatelet. So if you have blocked arteries in your neck, your heart, or your legs, you've had a heart attack, you had an angioplasty, you have angina, you can make a strong argument saying that clopidogrel or Plavix, when the price has gone down to this level, is a very reasonable agent to use. So I'm going to start switching people, and I start to make that switch as well. Some people use a combination of both. You mentioned the COMPASS trial, and especially if blocked arteries in your legs, things like Xarelto, rivaroxaban 2.5, and aspirin together. Or if you had a stent and a recurrent stents, we often use aspirin and clopidogrel more long-term. So we have lots of choices right now, but we're using shorter periods of blood clot or blood thinner. But the more important thing is how to prevent this disease from accelerating. So I think it's pretty exciting news in this area. So that's where we stand right now. So think about that for yourselves, what we should be thinking about. So next slide, please. So that's really exciting. But like everything, drug interactions, and the major interaction of blood thinners is bleeding. So let's learn a bit more about this. Tell us more.
Yeah, so if we go to the next slide, we can see that these are some medications that will increase the effects of anticoagulants, and increasing the effects of these anticoagulants would pose a risk of dangerous bleeding. And so some of the over-the-counter pain relievers that can do this are aspirin and your ibuprofens and Aleve. And then some other medications are shown below that can interact with your anticoagulants as well. So please make sure that your doctor is aware of all the medications that you're taking, and check with the patient information leaflet that comes with your medications for a full list of medications that you should avoid.
So this is actually very important. If you just go backtrack right now, people say if I have bad arthritis, what do I do? Well, Tylenol is the safest of all the medications. You can go for joint injections, but the moment you add things like Advil, Motrin, ibuprofen, naproxen, you increase the risk of bleeding complications by a factor by 40% or so. So on bad days with bad arthritis, maybe you'll pop an Advil, but I would not take these on a regular basis. Especially, and they're also harmful for the kidneys as well. So these are some of the things to think about. So thank you for sharing that. So really check with your prescribing physicians about this. This becomes a little bit tricky. Thank you. Keep telling us more.
And then on the other hand, these are some medications that can decrease the effects of your anticoagulants, which means that they can increase the chance of forming blood clots. So these are just some of those medications. And once again, keep your doctor informed on what you're taking and try to be aware of what you should avoid taking. Okay, so now let's go over some of the side effects of taking anticoagulants. So since anticoagulants affect your blood's ability to clot, the most common side effect is in fact bleeding. And these are some of the signs of serious bleeding. So this can be menstrual bleeding that is much heavier than usual. Maybe you'll see some red or brown in your urine. Bleeding that doesn't stop quickly. If you're coughing up red, if you have a severe headache or stomach ache, if you have any unusual bruising, if you have a serious fall that results in a bump on your head, these are all signs that can indicate serious bleeding. So if you notice any of these, please see your doctor. And then on the right-hand side are some other side effects. Some are more common, some are less common, and some depend on the type of anticoagulant you're taking. So if you're experiencing any of these symptoms while on anticoagulants, please tell your doctor. So as we've seen, anticoagulants do interact a lot with a lot of other drugs, but they also interact with other things that may be a staple of your day-to-day life. So it's possible that you'll need to make some lifestyle changes if you start on anticoagulants. So first, it's a good idea to try and avoid smoking and drinking alcohol while you're taking anticoagulants. Smoking has been shown to increase warfarin clearance, or its removal from the blood, meaning that the effects of the drug become reduced. And then alcohol in itself is a blood thinner, just as anticoagulants are. So combining the two can make it even harder for your blood to clot, and so it can cause increased harmful bleeding. So if you do make any big changes to your alcohol consumption, please talk to your doctor because you may need to have your INR level checked. And this will just tell your doctor how long it takes for your blood to clot.
So if I have atrial fibrillation, I'm on blood thinners, I'm not drinking. Is that, I'll drink on my birthday and anniversary. Basically, alcohol makes atrial fibrillation worse, makes bleeding worse. And so the other one thing that we haven't talked about in here is that fish oil supplements. Fish oil actually increase the risk of bleeding as well. So if you're taking a bunch of blood thinners, be careful about being on any form of fish oil supplementation. Those would be ones I'd be stopping. Thank you. Tell us more.
So in terms of your diet, you'll want to watch your vitamin K intake and try to keep it consistent. And this is because vitamin K is a regulator of your clotting system, and it helps your blood clot, which is the opposite of what anticoagulants do. So as a result, large doses of vitamin K can make your anticoagulant medications less effective. And if you look on the next slide, these are some foods that are high in vitamin K. So there's fish, liver, cheese, green tea, as well as a bunch of leafy greens. And then as well, if you take multivitamins, it's good to take one with a low dose of vitamin K. And then of course, this isn't to say that you shouldn't ever eat any of the foods that are listed here. It's just a good idea that you don't make drastic changes in your vitamin K intake and to not consume it in excess. And then additionally, if you want to take herbal remedies, be sure to consult with your doctor beforehand because certain herbs do interact with anticoagulants as well as with various other medications. And then to be safe, it's always a good practice to test your blood regularly while you're on anticoagulants so that your doctor can monitor how your blood is clotting and pinpoint if any changes need to be made.
So anticoagulants, the only anticoagulant you need to monitor is warfarin or Coumadin, measure an INR. The newer agents that called NOACs, Xarelto, Apixaban, Eliquis, Pradax, dabigatran don't need to be monitored at all at this stage of the game. So from my perspective is I want you to have lots of fruits and vegetables in your diet, but you should be on a regular basis. So you don't go from, 10 fruits and vegetables to no fruits and vegetables. And that's just for warfarin therapy. But most patients on warfarin, if you're stable, it's not an issue. If you're unstable, then we need to look into some of these dietary changes. So, that does happen. But to me, overall, for most people, it's not a major consideration at this stage. And if you're doing stable and you're doing well with your INR measurements, then I'm not too worried. But if there's some changes, we have to look into this. Absolutely, tell us more. So I'm going to first of all, what did I learn today? Is that we have heart attacks. Can you just put the next slide over here? Okay, just leave it at that right now. So basically, if I'm thinking about how to approach situations for prevention. So the best way to prevent a blood clot is to have, exercising, keeping my weight down, keeping my cholesterol, my blood pressure down. And then the next thing is going to be on different drug therapies. Can you go to the next slide here? I just want you to advance this slide over here. Keep advancing over here. All righty. This is something can you go to the next slide, please? Okay, go back a slide. So the slides that we did. Okay, we're gonna keep this slide here. Go back one slide again. All righty, good. Go back one slide. Go back one slide. Okay, now move forwards. Okay, move forwards again. Now the slides are appearing. So basically, good lifestyle changes. Next slide, please. All right. So if I have some blocked arteries, I have some angina, I get some chest pain, I get this tightness in my chest when I walk down the street. Dr. Curnew has done my stress test, shows that there's some mild changes. Amir, if you can show me that that vessel in that left-hand corner there, that's a stable plaque in there. That's a blocked artery. You can see the blood's getting through, but if you exert yourself, you don't get through to that. And one of the questions I have to say is, should I go for a bypass operation? Should we blow that lesion up with an angioplasty? And what makes you live longer in that circumstance? And you can see that lightning bolt comes down. It's basically lifestyle changes and medications. And that's something that people are having trouble with the concept. People say, "Oh, fix that artery in my neck, fix that artery in my leg, fix that artery in my heart." You know what? By fixing that artery in the heart, by doing a balloon or angioplasty, you actually make that artery unstable, and you actually form a blood clot in that vessel. And that's why you have to use aspirin, Plavix, clopidogrel, you have to use the ticagrelor. So to me, is that if I have a stable plaque, I'm going to treat that with the world's best medications. Remember that 80 milligrams of Lipitor or 40 milligrams of Crestor along with 10 milligrams of ezetimibe. If you have an LDL cholesterol 4, bring it down to 1, you can lower the risk of having a heart attack or a stroke by close to 60%. If my blood pressure is too high, if I weigh too much, that's what the things we need to do about this. And people are asking me, please do an angiogram. The answer is that we've proven that in 3 large randomized controlled trials. One's called Courage, one's called Ischemia, that's showing that the medicines, fixing the foundational problems, are so much more important. It's sometimes we do an angioplasty or bypass because it's a very severe blockages formation because of lots of symptoms. That's the number one reason for doing that. Or next slide, please. When I'm having a heart attack, and this is a situation, if you can show that those pictures on that left and right hand corner. So on that right hand corner, what you see, that cheesy plaque that's ruptured and formed a blood clot, that vessel is totally blocked off, occluded. We know in that circumstance, then that doing an angioplasty, giving a blood clot dissolving agent saves lives and saves heart tissue. And you can see the same picture on the other side. You can see the cross section. You see that cheesy white plaque that we treat with lifestyle changes and medications. And then when that clot is there, we know that calling 911, going to the hospital, the Hamilton General Hospital here in the Hamilton area, saves hearts, saves lives. In the brain, same thing too as well. In fact, the only hospital I would go to if I think I'm having a stroke or a heart attack is the Hamilton General Hospital, because that's the only place in Hamilton where you can get an angioplasty at 2 o'clock in the morning. And it's not you're calling your doctor's office. It's not going to another hospital. It's the hospital that does the angioplasty. Same thing in the brain. The Hamilton General Hospital does that. So wherever area you live in, know what hospital does the angiograms and the angioplasties, which ones helps you in stroke in that circumstance. And so we still need medications to stabilize the plaque. So what I learned today is that we have plaque. If you go back one slide again, is that I see that plaque on that left-hand corner. If we do an autopsy in people who die over the age of 60 years of age, 90% of us have some degree of plaque in that area. And the important thing is to fix that with good lifestyle changes, eat my fruits and vegetables, and take the right medications. And that's the key to your success. Next slide, please. If the plaque becomes unstable, that's when I need to call 911, go to the hospital. So right now, traditionally, if I blocked arteries, I was traditionally using aspirin therapy on a regular basis, 81 milligrams a day. But you can now make a strong argument using clopidogrel at 75 milligrams once a day is the number one antiplatelet agent. And I think I'm starting to switch. Maybe I should switch more significantly. If I have atrial fibrillation, I've had a clot in my leg, clot in my heart. Those are situations where you can use stronger blood thinners and they deserve your attention. But there's always a trade-off between bleeding risk and benefit. And that's why knowing what's your hemoglobin, knowing what's in your blood, it's really important. So, and I think you showed us very nicely that trials from Capri. And then now you also, if I have very diffuse blockages formation, I have in multiple territories, maybe that combination of Xarelto and aspirin may be a good thing. Would it be nice if they did rivaroxaban, Xarelto, and clopidogrel? Maybe that would be the trial of the future in that circumstance. But we have many things to offer. And please, if you smoke, stop smoking. Please, if you drink with these blood thinners, is that you're increasing your risk of bleeding. Avoid these anti-inflammatories. Avoid the naproxens, the meloxicams, the ibuprofens. On bad days, it may be worthwhile to take it, but not on a regular basis. So I want to thank the team for such a wonderful presentation, and I hope that's helpful. Any thoughts or comments? Amir, what you think?
I thought this was a really good summary on, talking about how atherosclerosis can worsen and develop into things like stroke and heart attack. I think the team and, you, Dr. Curnew, did a great job, talking about the different blood thinners and the benefits and stuff like that. And it comes back to, it looks like prevention is the best treatment for these things.
There's multiple phases. So one of the things we used to use when I first started practice, it was very common to take an aspirin pill a day to prevent a heart attack. And that was the therapy way back when. But the new aspirin is basically cholesterol, blood pressure, not smoking, lifestyle, weight reduction, better diets, better exercise. And aspirin doesn't really prevent the disease from getting worse. It prevents that terminal blood clot. Same thing with Plavix or the other blood thinners that we talked about. And if you have a blood clot in your lungs, you can die if you don't have the right blood thinners. If you have a blood clot in your leg that may move up, being on blood thinners is life-saving. Many cancers make your body thick. Overweight sitting around makes your body more likely to form clots in your legs that can move up as well. When you get a clot in the heart, that's a medical emergency room. It's 911. Get to the place that can treat you best. And that's why, is that I'm constantly late because I'm evaluating people that are concerned, and I will spend that time. Your job is not to need to see me by doing all the right things, and you can't prevent everything, but you can put a big dent to this. I want to thank the team for such a wonderful presentation. You reminded me how I should treat better and how we can do better. So I'm going to bid everybody a great night. Thank you all very much. Good night, everybody.